Next, I invite Dr. Manjima Mohan, working in Iris Eye Hospital, Kannur, for speaking on anti-VEGF injections, when, why, and what to choose.
Good morning, everyone. I'm going to talk about anti-VEGF injection, that is when, why, and what to choose. So, already my co-presenters have already talked about more about VEGF molecule, what they are doing. So basically, VEGF is the one that promotes vascular permeability, that increases the vasodilatation, and it basically increases the angiogenesis. So just by blocking VEGF, we can reverse this process and thus by limit the disease. So when to give the anti-VEGF injection? We know in diabetic retinopathy, the most common cause for defective vision is diabetic macular edema. When the diabetic macular edema is involving the center, we have to give a anti-VEGF as the first line. And when the macular edema is due to a vein occlusion, in central retinal vein occlusion or in branch retinal vein occlusion, we need to give a anti-VEGF. Then comes exudative or wet ARMD. If the patient comes with an active disease, that is a subretinal hemorrhage, a fluid at the macula, again we need to give anti-VEGF. Then in preterm babies, if there is a history of oxygen therapy and all, there is a chance of ROP that also needs anti-VEGF injection. And another indication is some VR surgeons prefer to give anti-VEGF before vitrectomy just to reduce the bleeding, so that operating time is reduced and risk of iatrogenic breaks are reduced. And also in neovascular glaucoma, just before IOP lowering procedures, glaucoma surgeons also prefer to give anti-VEGF. So in the market, we have many options available now. I'm just talking about a few agents which is available in the market currently we are using. So it all started with bevacizumab, and then came ranibizumab, then we had aflibercept, then brolucizumab, and recent one faricimab, and we have biosimilars as well. So what are the factors to consider when we give an anti-VEGF? For me, the first and foremost important thing is a safety. A drug should be equally efficacious as well as safe. We cannot give a drug which is not safe, but it should be balanced between both of them. See, in the olden generation, in the ARMD cases, we used to tell the patient there is no treatment before the anti-VEGF era, and then later laser came, and it was very efficacious. We can treat the lesion, but patient will lose the vision. So a treatment should be like, it should be safe as well as efficacious. So when Marina and Anchor trials, after Marina and Anchor trials, when VEGF came into play, so that was a revolutionized the treatment in neovascular AMD, where we can preserve the vision. So the next point is drying effect. So when the word drying effect comes, the first thing coming to my mind is the newer agents, that is brolucizumab and faricimab, which is having a better drying effect than the conventional agents. So if the drying effect is more, the frequency of injection, that is inter-injection interval, will be less, that is there. And the response to previous treatment, that is also an important factor. So if we treat a disease with one injection, and the patient is completely stabilized, and after some point of time, if the disease recurs, we can use the same agent which was efficacious for that patient. We don't need to switch when the recurrence comes. That is another point. And the regimen we are using, that is also an important thing. Being a developing country, most of us are following PRN base only. There is a treat and extend regimen also. Studies are using a treat and extend, but in the real world, it is practically it is difficult in a developing country like India. And the most important factor what I consider is the cost. Even if I tell, if a PCV patient comes, if I want to give an aflibercept, but if the patient cannot afford, obviously we have to go for the low-cost agents. So cost is the most important thing when we consider an anti-VEGF agent, because we have to consider that patient have to come to the hospital, the transportation, and the bystander, and their daily wage loss. So everything have to be in mind when we advise an anti-VEGF agent. And all the trials, we know all the agents have proven their efficacy and safety. And when we give an injection, we have to look at the disease, which disease we are treating. So in DME, we know not only the VEGF, some other molecule like inflammatory molecules, inflammatory mediators, that are also playing an important role. So we need to keep in mind that also. So only anti-VEGF, it is not the treatment. We have to go for other molecules as well. Then in wet AMD, as I already told, Marina and Anchor, these were the trials that revolutionized the treatment in wet AMD. Then we have the newer molecules as well, aflibercept, brolucizumab, and faricimab. These newer molecules, they are having a longer duration of action because the drying effect is more compared to the conventional agents. And when we come to the meta-analysis of neovascular AMD, when they compared brolucizumab, aflibercept, and ranibizumab, they all have similar visual acuity gains as monotherapy. All were having similar visual acuity gains. And also, when we look at the safety profile, they all were having similar discontinuation rates as well. Discontinuation rates means if there is a serious or non-serious ocular side effects, we will discontinue the drug. So all were having similar discontinuation rates, but the only striking thing was brolucizumab was having a better drying, that is central macular thickness reduction was superior for brolucizumab. It was around 39 microns in the first year and 35 microns in the second year. But when we closely look, we don't know actually whether this number is actually important when we look at the long term, because we don't know, we don't have the 3-year and 5-year data. And what we assume is, since it is having a better drying effect, it may be able to sustain the visual acuity gains in the long term as well. And when we look at the number of injections, the mean number of injections in the second year after PRN dosage for aflibercept it was 6.5, brolucizumab it was 5.7, and for ranibizumab it was almost a double, that is 11.5. So that is also there. So patient need to come more often with the conventional agents. The newer agents having a longer duration of action, but we don't have that much evidence to tell about the safety. And that was about AMD. And the DME also, the meta-analysis is showing equal comparable visual acuity gains in all the agents. Only in the first year, the aflibercept and brolucizumab was having an extra edge over ranibizumab. But when we look at the second year, all the agents were having comparable visual acuity gains. So that is why I'm telling we have to look at the long-term results than the immediate effect. So when we talk about the safety profile, we know when bevacizumab was given, initially there were reports of cluster endophthalmitis. Then we had ranibizumab, and biosimilars also came. And ranibizumab was having 1.5% of inflammation in Anchor and Marina trials, but there was no vasculitis. Aflibercept, it was 1.1. So basically, ranibizumab and aflibercept, both of them having an extra edge over the newer molecule in terms of side effects. So brolucizumab was having 4.6% of intraocular inflammation in Hawk and Harrier study, and vascular occlusion rate of 2.1%. But so the brolucizumab side effect is real, it is there, and the better thing or the good thing about this brolucizumab side effect is it is treatable. So the patients are treated with topical steroids and oral steroids, and their condition improved. So that is also there. So when we consider these kind of agents, we have to select the patient properly. And we have Indian studies as well, where they compared newer agents with the brolucizumab with the aflibercept in RR Hospital, New Delhi. They conducted a study. It was a RCT, and they also found comparative visual acuity gains. But they were also telling about the drying effect of brolucizumab, which is more, especially in the subretinal compartment. So the inter-injection interval was more with the brolucizumab group. And another study, Braille study, again from in Indian patients, it is also shown efficacy of brolucizumab. And after 126 injections, there were no case of inflammation in patients. So basically, what we see from Western population, the side effect is more with the Western population than the Indian patients. And the newer molecule faricimab, it is a dual antibody that is blocking VEGF as well as angiopoietin 2. And in the TENIA and LESSON trial studied for neurovascular AMD, that also showed that brolucizumab is not inferior to aflibercept. And in DME also, Yosmet and Ryan studies, it proven the same non-inferiority of brolucizumab with aflibercept. But the striking thing there also is, after the loading dose, the maintenance phase, aflibercept was given 8 weekly, but we can extend faricimab a little more. That is something around 12 to 16 weeks in patients. So in conclusion, there is no one anti-VEGF for all disease. We have to select according to the patient. It is a tailored approach always. The conventional agents, ranibizumab and aflibercept, it's always efficacious, and it is having a cutting edge over newer agents because of the lesser side effect profile. But newer agents, brolucizumab and faricimab, both are having a promising results because of the better drying effect and longer inter-injection interval. So we have to consider all the factors when we choose an anti-VEGF. So patient selection is important. We don't want to take a chance in a one-eyed patient, so we don't want to give brolucizumab in a one-eyed patient. And patients who are prone for inflammation, we don't want to give brolucizumab in those kind of patients. And patient education is also very important when we give anti-VEGF injection. So cost is one of the important factor in deciding which anti-VEGF to